Masih dalam. Masih dalam.
Apa? Mr. Nang Tak Ming of Hong Kong Radiographers Association, HKRA, to President Chun Yuan Tu of the Taiwan Association of Medical Radiation Technologists, to Malaysian Society of Radiographers President Mr. Sawal Mar Said, to President, here I see President Vitarana Gamage Vimalasena of Society of Radiological Technology Sri Lanka. Maybe here.
Hello. 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 Yes, I can hear you. Yes. Thank you for inviting, and a greeting from Sri Lanka for the Singapore Society of Radiographers. Okay, thank you very much.
Thank you, President Vimalasena. We also received greetings from President Sophie Lee of the Association of Cambodian Radiological Technologists, from President Abdul Ghani of Palestinian Association of Medical Radiation Technologists, from Indian Society of Radiographers and Technologists, President Mohan Lai Bhagwat, from President of Japan Association of Radiologic Technologists, JRT President Katsuhiko Ueda, from President Taiwan Society of Radiological Technologists, President Hui Yuan Wu, President of Philippine Association of Radiological Technologists, President Ruben Lorenzo. Also here, allow me to also recognize our invited panelists. We have Ma'am Cora Nang, Vice President Chin Chun Yu. We have Putu Adi Susanta from Indonesia. We have also, we have Sibila Intesen from Laos. Again, enthusiasm and optimism, I welcome you all to the 49 CPD Asia, and I hope to meet all of you again as the Philippine Association of Radiological Technologists hosts the next month's CPD Asia. Again, let's make this program a truly remarkable experience. Thank you, Natanya.
Hello, thank you, PG. Okay, so without further ado, welcome to today's academic session. So my name is Natanya, I'm your moderator for today. My voice is a bit husky today as a result from snacking too much. So yeah, balanced diet is very important, guys. So for today, we have 4 incredible speakers with us who will be sharing their take on insights that inform and transform practice. Okay, so please note that at the end of today's session, there will be a feedback form where you may share with us how you felt the overall session was. For Singapore participants, please fill in your HPC number for CPE points to be provided. Next, for today's program, we've invited both radiographers and radiation therapist speakers so that audiences from both professions can take something home today. However, in the event of an overrun due to time constraints, please take down this email and send us your inquiries where we will direct them to the speakers. So first up, SSR is very excited to introduce our first speaker, Sam Chong. Sam Chong, with over 2 decades in radiography, he currently serves as a senior principal radiographer at CGH. So Sam supports healthcare cluster through his work as cluster education leader and clinical education lead at CGH Education Office. He's also a vice chair for radiation and imaging sciences. So he was also my lecturer at SIT and received many awards, including the National Day Efficiency Medal for his service. But before Sam delivers his presentation, let's welcome Denise first to deliver her welcome speech. Denise, are you online?
I am. Can you hear me?
Yes.
Okay,
sorry about
great.
that.
No problem. Thanks very much, Natanya. So, and thank you very much, Peachy. So, good afternoon, friends and colleagues, and thank you for joining us today for the 49th CPD Asia webinar, hosted by the Singapore Society of Radiographers, SSR. So, we thank you all for your time, active participation, and support for CPD Asia. As Peachy shared, like we have been doing this for 5 years already, and I can't believe that it's been so long. But because of your active participation, we can continue to bring these kind of important professional topics to radiographers and radiation therapists all over Asia. So today you'll notice that our talks center a lot around the impact that our imaging and therapy has on our patients, and not just as a patient, but also as a person. So it's sometimes easy to forget, like when we're so busy every day. But actually, patient care is really still at the core of what we do every day. So thank you again to our speakers and our academic team at SSR for preparing the great lineup of talks today. I'm sure they will all be very enlightening. So do enjoy this webinar and let's have a lively Q&A session after. Okay, back to you, Nat.
Thank you, Denise. Okay, so without further ado, we will introduce Sam, our speaker. Thank you. Sam, you can unmute yourself now.
Hey, thanks, Nat. Just give me a, can everyone hear me?
Yes, we can hear you.
Okay, can. Just give me a few seconds to set up the screen. Can everyone see my PowerPoint? Okay, hey,
Yes,
thanks a
Sam,
lot.
we can.
Hey, thanks, Denise. First of all, thanks SSR for the kind invitation. And then hi Nat, and thanks for the kind introduction. Nice to see you here at this platform. I know time is precious today, so I will start my sharing first, okay? My topic for today is seeing the seeing the person behind the image, patient-centered care in radiography. By the way, my name is Sam. I'm a radiographer working in Singapore in Changi General Hospital. Okay, so just a disclaimer, just a heads up. This presentation is based on my own understanding and learning about PCC, or patient-centered care. Just take note that I'm not an expert at this area. Today, this is just really for learning and discussion, and it's not a professional advice. So the hypothetical examples that I've shared are just to help us explore or understand the ideas around PCC in radiography. So this is the content for today. I'll be sharing my understanding of PCC, and then I'll also highlight the importance of PCC in radiography. I will also share some possible challenges in implementing PCC, and then share some practical implementation tips. And finally, we'll explore the positive impact of PCC. So what's the aim of today's presentation? Simply it's just for me to share how simple and personal touches in radiography can actually help to make our patient feel more comfortable and cared for during the imaging care that we provide. So imagine this, okay? Imagine you're in a waiting room at a busy hospital. You have been told that you need an X-ray, but you're unsure what the procedure will be or why it is needed. Then the radiographer call your name and you follow them into the room. There's no introduction, no explanation. You have been just asked to change your gown and lie down. Then as the procedure begins, right, you left with questions. Why do I need to do this test? What is this test for? And you wonder if your concerns about radiation has been considered. And before you can ask anything, the radiographer is really moving on to the next task. And you felt more nothing than a case number or just a case. So imagine you are the radiographer in this scenario. What practical actions will you take to improve the patient's experience and comfort during the procedure? My apology in advance because I'm using a free account for Poll EV. There's a limit in number of participants who can join this poll. Can I trouble you all to take out your mobile phone and scan the QR code? All right, and then share what are your thoughts. Imagine you are the radiographer in this scenario. Okay, what action do you think you can take to improve the patient's experience and comfort? I see greeting the patient. Smile, that's a good one. You know, that will help to elevate some stress. Introduce ourselves. That's important also, you know, letting the patient know, who is doing this x-ray for me, doing this examination for me, giving clear explanation. Explain. Thanks. I think I'm hearing, common themes like explain. Oh, my apology. Explain, reassuring the patient, introducing ourselves. I think you all have more or less got it correct, and these are important concepts in patient-centered care. Thanks for the engagement. So in the next few slides, I will share some of my learning and understanding in PCC. Okay. As what you all have rightfully pointed out, simply put, what is PCC? Basically, PCC means putting the patient at the heart of all we do. It means listening to them, like what some of you have shared, being kind, being respectful, involving them in the decision, and caring for them as a whole, not just their illness. So that's a simple definition of PCC. And historically in radiography, the challenge is we are all about using technology and getting the scan done quickly because of the high workload. And often what happens is things like patient's comfort or good communication are oftentimes overlooked. But what is the current expectation? What's the expectation of our patients today? You realize that actually more and more patients expect to be treated with kindness and respect. And they do want to have a say in their care and decision. Next, I just want to share a short video that is produced by WHO on the definition of what is people-centered care or patient-centered care. Just take note that people-centered care or patient-centered care are quite loosely used interchangeably. All right, let's watch the video. I hope the short clip is able to give everyone a short, good introduction to what is PCC. In the next section, I will share why PCC is important in radiography. So, I think many of you will have realized that radiography is actually the first thing that most patients encounter. And you can imagine that if the experience feels cold or confusing, it can make them lose trust in the care that they will receive. And studies have shown that there's a gap in how radiography or how radiographer perform imaging care or give imaging care to our patient. Often than not, we are so focused on getting the job done that we don't always make time to talk to our patient. If you can remember earlier on the scenario that I shared with you all, asked you all to reflect and think about. Remember, the radiographer was in such a hurry, does not take the time to explain the procedure to the patient. As a result, the patient will feel anxious and confused throughout the procedure. Likely what will happen, the patient will leave the imaging department feeling unsatisfied and distrustful of the organization. So why is it challenging to implement PCC or patient-centered care in radiography? Why is it difficult for a radiographer to adopt PCC? I think one of it could be due to communication and cultural sensitivity lapses. A study done by Chow has found that actually many radiographers are not ready to meet the patient's different cultural needs, especially when things get busy. Miscommunication can happen, and when miscommunication happens, patient get confused, they don't understand, and then there's a reduce in trust in the radiographer, resulting in a lower quality of care. What is another thing? The variability in training. Recent graduate might have the potential or might be exposed in patient-centered care training, but probably this is not the case in many for experienced radiographer. Even for myself, traditionally in our radiography education, what is the focus? The focus is on the technical aspect of radiography, the physics and instrumentation, how to do positioning. There's a lack of transferring of soft skills knowledge to us. Example, the focus on patients' needs and preferences. So with all this, what are some of the practical implementation of PCC? How can we implement PCC in our daily work? First of all, what I've learned is individualized attention. Just remember that each of our patient is more than a case number. Each of our patient have their unique stories, their emotions, and their concerns. So if I can help to illustrate, imagine a patient comes in for MRI scan. Patient is anxious and mentioned to the radiographer that, or mentioned to me that he has a bad experience with a previous scan. So what can I do? The radiographer can take the time to listen to the patient's concern, explain the procedure to the patient using simple terms. Earlier on, like what you had shared with me, explain. Reassure the patient. I also see the point some of you had mentioned about reassuring the patient, and periodically checking the patient to ensure that the patient is comfortable and promptly address the concerns. What's the next pointer? Understanding needs and preference. Remember, some of patients might have concern about radiation or they are worried about their result. Another thing is respecting their cultural and religious belief. So if I can help to put things in context, let's assume a patient coming for a CT scan. She expressed concern about the radiation exposure. Instead of just brushing it aside, the radiographer takes the time to explain the safety measure to the patient, to reassure the patient again, reassuring the patient. And the other thing that the radiographer can do is respect the patient cultural preference and modesty by providing a blanket. Simple action like this can help to ensure privacy and to make patient feel comfortable during the imaging procedure. Next, shared decision making. Involve our patient whenever possible. Example, explaining the use of contrast. So, example, if a patient comes in for an MRI scan, the radiographer takes time to explain the contrast agent will be used, what are the side effects, again, takes time to explain the risk and benefit of using the contrast. Why is it important? Involving the patient in the decision-making process. Last but not least, effective use of effective communication. And one way to allow or to promote effective communication is to use clear, jargon-free language. Avoid using complex or difficult medical terms. Don't assume that our patient will understand. Sometimes what we can do is use visual aids. Visual aids might help our patient. So imagine you have a patient that comes in who is hard of hearing and struggle to understand what you are trying to say. You can use clear, simple language and use visual aids to explain the procedure to the patient. And one trick sometimes I use is, talk to the patient at eye level so that the patient can see our face, see our lips. This can help to promote better communication. Some simple tricks, how you can implement PCC. Before procedure, greet the patient. Remember, some of you have shared with me about this one. Introduce ourselves. Explain the scan to the patient. And before you start the positioning, before you start the examination, check the patient. Do you have any concern before I start the examination? And during the examination, offer step-by-step instruction. Reassure the patient. And then you can use gowns or blankets to preserve patient modesty. Then what happens when you're done with the examination? Don't just send the patient off. Explain what's happened next. Example, the doctor will go after the examination. The doctor will please remember to go and see your doctor because the doctor will explain the result to you. And then encourage question. Ask the patient before you go off, do you have anything that you want to check with me? Do you have any questions? So these are some simple tricks that we can use to implement PCC during our daily work. And remember the 4 points that I've shared. Remember, individualized attention. Each patients are different. They have their own needs. Okay, understanding their needs and preferences. Involve patient in the decision-making process, shared decision-making, and making use of effective communication. Avoid using medical jargons, use simple language, and when necessary, use appropriate visual aids. So I just want to sum up how does PCC can impact our care on imaging care. So when radiographer takes the time to explain what will happen and show care, patient will feel more at ease. They're more likely to stay calm and still, which help us to get clearer images. What does this mean? It means fewer repeats and it can save time. And clear images can also help our doctors to make quicker and better diagnosis. And when radiographer work closely with doctors and share useful patient information, it builds better teamwork and leads to better care. And for a radiographer, please remember, it's not just about taking images. It's about making patient being feel looked after, which makes our work more meaningful. So I just want to give a closing thoughts. As I conclude my presentation, I just want to reiterate that it's essential that we remember that patient care, imaging care, extend far beyond technical aspect of imaging. Please remember, each interaction with a patient is a chance to offer comfort and reassurance, which can significantly impact their experience in the hospital. Let's carry this thought forward in our imaging practice, in our care. Thank you. So these are my references, and with that, I will end and I will conclude my presentation. Thank you. Thank you.
Okay, thank you, Sam.
Hey, thanks, Nat. I will stop sharing.
Okay, so there was a wonderful session by Sam. Next up we have ST Ong from National Healthcare Group. So ST is a radiographer and has won the Book Prize Award and MOHH scholarship. So ST will now be sharing on communication, curiosity, and self-awareness, and how they can shape more thoughtful and connected healthcare workers. So without further ado, ST, please.
Thank you, Nathaniel. Hold on, let me just share my screen. All right, can everybody see my screen? All good? Can. It's all good, yeah? Okay, so without further ado, I'm just gonna start. Okay, firstly, thank you SSR for the opportunity to be able to, represent and talk about, beyond the image. I actually do have a lot of thoughts about it when I received this topic, and I'm gonna talk about insights that actually inform and transform practice. All right, so a little thing about me. Okay, I'm a radiographer in National Healthcare Group Diagnostics. I actually just graduated last year in Singapore Institute of Technology, and currently I'm an alumni. Very, very, very honored to also receive the Citizen Leadership Award back in my university in 2023, as well as the MOHH Book Prize Award last year during my graduation ceremony. So some hobbies about me for the funs is I love vlogging and I love meeting new people. All right, so first, let me just talk you through, one moment that actually sparked my thoughts of this presentation of, being beyond the image. There was actually a lady who came in twice for X-ray, differing regions, but both times in a wheelchair. So during her first visit here, she actually opened up about her family struggles and, just needed a listening ear, just someone to actually listen. So I happened to be that person. So the second time she returned, she was visibly in pain, but despite so, what struck me the most was still her smile. She was genuinely happy to be imaged again, which was, weird. But so after that, it's just, when she told me, it's simply because I was there that, brought her through the pain. Because she told me that, she don't have any children of her own, but that talking to me gave her comfort and that she was so glad to be seeing me doing well. So that moment stayed with me even long after the images have been sent, because it reminded me that, we don't just capture anatomy, we actually hold space for people. So this was one of my first true insight where I had a shift from being image focused to being patient centered. For the first point of beyond the image is about seeing the person and not just the pathology. So for the first point, patient unjust cases, Sam mentioned just now earlier as well, they're actually people with stories. When you take the time to listen and engage with the patients, it actually can reveal vital context. So, sometimes a request from the physician or the clinician simply says, for example, foot injury, but where, what kind, and how did it happen? So that's where we come in as radiographers to actually ask the hows and whys to improve radiology's reporting. So this brings me to my next point, where effective communication and rapport building with patients will actually elicit better history taking as well as diagnostic treatment. For example, for the foot injury, let's say the pain is at the base of the fifth metatarsal, at least we can write in a procedure remark saying, oh, there's bruising seen or, pain at the base or the lateral aspect of the foot. The third point, emphasize on rapport building. So in clinicals, I actually learned to adapt, to speak without medical jargon, and actually position patients with disabilities to actually slow down and listen to the patients. Every time I chose to connect with the patient before I position, the image improved, not just technically, but holistically. We often think of efficiency as speed, but actually, fun fact is true efficiency includes empathy. The fourth point on adaptability is actually quite a clinical skill. no two patients are actually the same, which means there's no one-size-fits-all imaging technique. It's actually in those moments where we actually pause, assess, and tailor our approach to meet the patient's unique needs. Lastly, on mobility, when you tend to take the time to assess the patient's mobility, it's actually very important where improvisation may be required. So there was this once, okay, when I actually handled one of these patients. He was a double lower limb amputee patient who needed a knee x-ray. Truth to be told, I actually froze for a minute because I'm like, oh dear, how am I supposed to plan the position? So when I took the time to think and actually plan, right, the patient actually, before I could even act, the patient said, oh, I took it before in hospital. Come, let uncle teach you. I show you how. So that's when I laughed, we both laughed, and he even told me, oh, I think I can be radiographer already. So I think that moment actually reminded me that, patients aren't just passive. They actually bring wisdom and humor too. So take a moment, think of a patient who actually made you pause. What did they teach you? It's these quiet insights that actually remind us we're not just service providers, we're actually healers, connectors, and professionals. So the second point on Beyond the Image is my take on embracing growth beyond competency. So this GenMed Cosby clinic, which I helped establish in 2023, was actually created with a simple but important goal: to actually give my junior radiography students the confidence and competence they need before stepping into their first clinical attachment. It's actually a peer-led initiative where my senior radiographer students actually guide juniors through practical skills and exam stations, like the short GIF you can see at the bottom left of the slide. And this is not just to prepare them technically, but actually to reassure them that, hey, you guys are not alone, because we experienced the same thing before. So this initiative is very, very close to my heart, and I'm very deeply honored that it was recognized with the awards I mentioned earlier. But more than that, what means the most to me is seeing it continue as a tradition, passed down from one batch to another. And for all of us here as practicing radiographers, I just want to give a little reminder that mentorship doesn't have to be formal. A little guidance, a shared tip, a moment of reassurance on the floor, these can actually mean the world to someone just starting out. We all have the power to shape somebody's clinical journey the same way someone once shaped ours. So firstly, I just want to thank my collaboration with Singapore General Hospital as part of my honours thesis back in my final year, when my team conducted a pilot study to assess radiation knowledge among radiographers across differing modalities, as well as referring physicians. So one key finding actually stood out. Those who rarely engage in continuous professional development sessions scored significantly lower in their understanding of radiation doses, risk, and protection. So this shows that it was a clear reminder that, CPD isn't just a checkbox for compliance. It's a professional responsibility. Because when we stay informed, we make safer, smarter decisions for our patients. So as you can see in the bottom left, even from this small sample of our pilot study, we can actually, tell that active CPD participants actually consistently scored better in the quizzes. Imagine the impact if this was studied at a bigger scale. Also recently, I had the opportunity to present a CPD session on normal variants and its imaging in upper extremities to my fellow colleagues in NHGD. I actually covered cases that are often overlooked, not because they are unimportant, but because they don't show up every day. Things like, is there a growth plate or fracture? Yeah, so these common questions and being able to spot these subtle differences can actually significantly impact a patient's journey, like ensuring timely transfer of a patient to a treatment room for proper stabilization. So this session and research, when I did for this CPD talk, actually reminded me that competence might get us into the room, but it's insight, reflection, and the willingness to keep learning that allows us to stay and eventually to lead. The last point I'm going to talk about is advocating for the future of our profession. So people often ask me, why YouTube? Why speak up at forums? My answer is simple. If we don't speak up for our profession, then who will? We're not just button pressers, we're actually critical thinkers, patient communicators, and essential players in a diagnostic journey. So when I started my YouTube channel, my goal was to offer aspiring radiography students a window into our world, to actually guide them through real experiences and help them step into the field with clarity and confidence. And every time a junior tells me, your videos help me choose this path, it reaffirms why this work matters. But here's the thing, You don't need a YouTube channel to advocate. Although if you do have one, I'll definitely subscribe. Okay, but every conversation you have with a student, every patient you educate, every interdisciplinary team you collaborate with, it all helps shape how the world sees us. So whether you're speaking at school, posting on LinkedIn, or even mentoring someone new, sharing a success story with pride, you're actually advocating. Because when more people understand our values, our role grows stronger, not just for us, but for the generations of radiographers to come. So I want every radiographer here and out there to know this, that your role is bigger than you think, that you matter deeply in this healthcare ecosystem. Think about it. Even in shows like Grey's Anatomy or like hospital playlists, what's the first thing the doctor shout when a trauma patient rolls in? Get me a chest x-ray or stat CT now. So before they even cut, stitch, or diagnose patients, they actually need us. Because no matter how dramatic the scene, the truth holds that imaging guides action. The patient you x-rayed yesterday, he may now be getting the right treatment because of the images you captured. We may work quietly behind the scenes, but make no mistake, and our work will drive diagnosis, guide care, and saves lives. Even when it feels like no one notices us, know this, that you are seen, valued, and patients are doing better every day because of what we do. Thank you for your service and for the impact that you make, image by image. So I am going to end my personal motto, and it's helped me step into the unknown, from speaking to leading and to learning. What's the worst that can happen? It won't be the end of your life, but it might be the start of something better. And here's a photo I always look back on, a moment I'm truly proud of, and a reminder of why I do what I do. Thank you.
Okay, thank you, SD.
Thank you.
Okay, thank you, SD, for the wonderful insights. Next up, we have Lala, who is a radiation therapist at National Cancer Center. So she was awarded the Book Prize Award for her thesis and will be sharing on medical humanities to the field of diagnostic and therapeutic radiography. So without further ado, let's welcome Lala.
Hello everyone, can you see my screen?
Yes, we can see your screen. Thank you.
Okay, good afternoon everyone. My name is Lala and I'm a radiation therapist from the National Cancer Center Singapore. When I first came across the theme of this conference, the first thing that came to mind was how tech-centric the program might be, with the spotlight on artificial intelligence and other emerging technologies forming our field. However, I would like to take this opportunity to explore a topic that is equally relevant to the theme, yet quite different in nature. As diagnostic radiographers and radiation therapists, we are constantly striving to improve our clinical processes, working in while the rest of us may have some form of encounter with it through life experiences. I'll now be taking a closer look at this quality and exploring how the field of medical humanities can support us in cultivating this important soft skill. So empathy can be defined as a healthcare professional's recognition of and self-regulated response perspective on the illness experience. Their relevance in preparing physicians for 21st century challenges, the Association of American Medical Colleges advocates for greater integration of the arts and humanities into medical curricula. These recommendations are reflected in the growing number of institutions incorporating humanities-based courses into their programs. In the academic year of 2017 to 2018, approximately 94% of America's medical schools included medical humanities in their courses. In Singapore, the Lee Kong Chian School of Medicine has also incorporated the humanities into its curriculum. While it was previously limited to just the first 2 years of the degree program, medical humanities has been taught across all 5 years since 2024. Similarly, at Duke NUS Medical School, students on their palliative care posting are required to engage in a dramatic stage play as part of a novel education program. At the National Cancer Centre Singapore, a pilot study was conducted to evaluate a humanities-based program designed to foster empathy among junior doctors. This program, known as the Humanistic Aspirations as a Propeller of Palliative Medicine Education Program, or the HAPPY program in short, was found to be feasible, acceptable, and efficacious. Although the humanities are gaining recognition and integration within the medical profession, their presence in the allied health domain remains limited, at least in the Singapore context. As a result, there is a lack of knowledge regarding its potential benefits for this field. Given the direct involvement of allied health professionals in patient care, medical humanities may also be of significant relevance to this professional community. So this is where my undergrad honors thesis comes in. And here's my poster. It's the final product of all the effort that I poured into my final year at university. I will now provide a brief overview of my research. Drawing inspiration from the study on the HAPPY program, which I mentioned earlier, I sought to explore similar outcomes among allied health students. More specifically, the aim of my study was to investigate the feasibility, acceptability, and efficacy of a medical humanities-based educational intervention designed to cultivate empathy among them. As a pioneering initiative, it introduced medical humanities to the field of allied health. Consequently, the findings would aid faculty members in assessing whether this novel teaching approach should be introduced to the allied health curriculum. So here's a quick overview of my research process, which involved the administration of questionnaires at the beginning and end of an intervention. During recruitment, a mass email was sent to all allied health students at the Singapore Institute of Technology who had completed at least one clinical placement and thus had prior experience interacting with patients. The intervention involved a medical humanities-based workshop centered around the medium of applied theatre. It was conducted in a single session with a total duration of 9 hours. It was crafted and facilitated by a PhD candidate from the Medical Humanities Research Cluster at Nanyang Technological University of Singapore, and she had prior experience conducting workshops for doctors, nurses, and medical students. So this table outlines the detailed schedule of the intervention. Since the program was centered around the medium of applied theatre, you'll notice activities titled Image Theatre and Forum Theatre included in the lineup. The workshop activities required the active participation of students. At the end of each activity, a debrief session was conducted to help participants relate the activities to their clinical experiences. These sessions played a crucial role in the learning process. So an adequate amount of time was allocated to ensure that the reflective processes were not rushed. And here's an overview of the outcome measures that I used. I adopted a mixed methods approach. So feasibility, acceptability, and efficacy were assessed through quantitative methods. On the other hand, qualitative data were collected through a post-intervention survey. These responses offered deeper insights into participants' experiences during the workshop. In terms of quantitative measures, the intervention was deemed feasible when at least 80% of the participants completed the workshop. Acceptability was retrospectively assessed using a questionnaire that was developed in accordance with the theoretical framework of acceptability. Lastly, to evaluate the intervention's efficacy, the Jefferson Scale of Empathy was administered before and after the workshop to assess changes in the participants' empathy levels. This slide provides a quick overview of when the different questionnaires were administered. Unlike the Jefferson Scale of Empathy, the acceptability questionnaire and qualitative survey were only administered after the intervention. Now let us move on to the results. I managed to recruit a total of 10 participants, and all of them happened to be from the diagnostic radiography program, even though the workshop was open to all allied health students in the university. But on the bright side, I guess that makes my data even more relevant to all of you here today. This table summarizes the quantitative outcomes. The results were very promising across all three aspects. We achieved a completion rate of 100% and a high mean score on the acceptability questionnaire. A PET-D test also detected a statistically significant increase in GSE scores among participants, indicating that the workshop had a positive impact on empathy. All of these point towards the fact that the intervention was feasible, acceptable, and efficacious. Let us have a look at what this means. In terms of feasibility, a completion rate of 100% indicates a high level of retention, which suggests that the intervention is realistic to implement. On top of that, the high scores obtained in the acceptability questionnaire indicates that the participants were receptive towards the intervention. Together, these findings point to an intervention that is well suited for the target population. The workshop's efficacy was demonstrated by a statistically significant increase in GSE scores. In other words, the participants became more empathetic after attending the workshop. These changes can be clearly visualized on this graph. Similarly, empathy outcomes have also been observed in several other studies in which medical humanities had been successfully implemented. These studies involve students from a range of healthcare disciplines, including medicine, pharmacy, dentistry, and nursing. One of these studies actually used an artistic discipline that was similar to the one I used in my intervention. In this study, medical and pharmacy students took part in a 40-minute workshop centered around a theatrical performance. The outcomes were very encouraging, as the Jefferson Scale of Empathy showed an immediate improvement in the students' capacity for empathetic engagement. These promising results, observed in both medical and pharmacy students, suggest that the relevance of medical humanities may extend beyond the field of medicine. Thus, they support the idea that the discipline isn't confined to a single professional group and can also be utilized in allied health education. There's another study that I would like to highlight. It compared a group of medical students who took an elective course with their peers from the same cohort who did not. By the end of the academic year, students who took part in the intervention showed higher levels of empathy, as measured by the Jefferson Scale of Empathy. Apart from demonstrating the effectiveness of medical humanities as an educational medium, these findings offer additional insights into how empathy outcome might differ between students who choose to take a course and those who don't, if an elective like this were ever offered to allied health students. I just referenced a few studies with results that are similar to mine, but I would like to highlight a few considerations to keep in mind when reviewing the literature. Firstly, there is a limited number of studies involving a similar demographic. This stems from the fact that my study is among the first to explore the use of medical humanities in allied health students. Additionally, it's important to acknowledge the inherent uniqueness of medical humanities programs, as they can vary widely in structure and design. And because of this, caution should be exercised when comparing the outcomes of different studies. Instead, the findings should be viewed as complementary. Together, they help expand educators' understanding of the field. So moving on, let us have a look at the responses to the qualitative survey, which allows us to better understand the participants' experiences during the workshop. When asked whether they would sign up for a medical humanities workshop as an elective, 9 out of 10 participants responded positively. They cited reasons such as personal development, the module's relevance to the profession, and a positive learning experience. Interestingly, one participant mentioned that they will only enroll if the module is graded. And in addressing the question, how do you think the workshop might have influenced your understanding of empathy, a recurring theme emerged. It opened participants' eyes to perspectives different from their own, including those of patients, fellow students, and other stakeholders. The importance of understanding others' perspective was also emphasized. When asked whether greater challenges in empathy might come from regular participation in workshops rather than a single-day session, 9 out of 10 participants expressed a preference for consistent engagement. To them, empathy is a soft skill that develops gradually and requires more time for cultivation. Moreover, knowledge and skills are thought to be reinforced through consistent practice. One of the respondents even shared that there might be a tendency to forget what they have learned after a single-day workshop. Finally, recommendations for improvement pertain to the workshop's duration, the overall conduciveness of the learning environment, and the availability of resources for note-taking and learning. The provision of notes and worksheets was also proposed as a way to help enhance the learning process. All of these responses should be taken into consideration when designing future iteration of the intervention, which will not only improve participants' experiences, but also improve the program's overall efficacy. Of course, like any other study, mine had its limitations. With a small sample size of just 10 participants, and all of them being from the diagnostic radiography program, the sample wasn't exactly representative of the broader allied health student population. Next, regarding the outcome measures, when I designed this study, there was an absence of measures developed to quantitatively assess feasibility and acceptability within this context. To address this challenge, the most suitable measures of feasibility and acceptability were utilized, but they were not ideal. Lastly, as a self-reporting tool, the Jefferson scale of empathy may not accurately reflect how others actually perceive an individual's empathy. In other words, a high empathy score doesn't always translate into observable empathetic behavior. Nonetheless, having a stronger empathetic attitude does make it more likely for someone to express empathetic behavior. Therefore, the relevance of this study should not be dismissed. Overall, the results to this study was very positive and encouraging. Apart from yielding promising outcomes across 3 study aspects, which were feasibility, acceptability, and efficacy, the medical humanities-based workshop was also very well received by the participants. So at this point in my presentation, I've mostly been talking about the use of medical humanities in the educational setting, and you might be wondering how any of this applies to you as working professionals. Beyond just cultivating empathy in students, the arts and humanities can play a wide range of roles across the healthcare landscape. So this diagram provides an overview of how the arts and humanities can be incorporated into academic medicine. The 3 areas of application are education, which I have discussed earlier, patient care, and research. The first area of application has already been discussed earlier, so I won't go further into it in the interest of time, but I would like to leave you with one final note. It's important to be mindful of potential barriers when introducing medical humanities into the curriculum. Firstly, this educational approach demands a high level of personal engagement, which some may find excessively intimate and intrusive, as well as evoke strong emotions. So not all educators or students will feel comfortable delving into such personal matters on a regular basis. Secondly, some students feel that facilitators without a healthcare background struggle to grasp clinical realities, which can affect how credible or relatable they seem. Lastly, humanities-based programs are often criticized for their placement within the curriculum, occurring either too early when students lack awareness of clinical realities, or too late when they are preoccupied with assessments and the acquisition of clinical knowledge. Thus, all of these factors will need to be taken into consideration when deciding how best to implement medical humanities. The arts and humanities can also be employed in patient care. As mentioned earlier, they offer perspectives on the illness experience through neutral and safe approaches that both healthcare providers and patients can understand. So this establishes a common ground which in turn fosters humanistic connection between them. In particular, words and narratives are powerful tools that facilitate connection and mutual understanding between clinicians and their patients. For example, books like Being Mortal and When Breath Becomes Air became bestsellers because the author's honest and personal reflections on death and dying had resonated with both patients and healthcare providers. By appreciating the narrative of a patient's life, we come to understand that illness is not just a disruption of biology, but also a disruption of biography. This perspective helps us recognize what truly matters to the patient and thus allows us to provide care that aligns with their core values. Additionally, the humanities may also play a role in bioethical discussions. The humanities also play a role in addressing burnout by facilitating the expression of complex and difficult emotions. The act of perspective taking helps one find comfort in uncertainties. Finding a common purpose also allows one to develop a sense of meaning at work. Furthermore, these activities provide a glimpse into aspects of our colleagues beyond their roles as co-workers, which help humanize one another. The poem on this slide is an example of how poetry can be used as a medium to facilitate reflection through creative expression. Through this poem, the author reflects on his professional journey in medicine and how his interactions with patients shape both his passion and choice of specialty. In the realm of research, the humanities can actually lead the way in generating new knowledge. This quote by Carlo Rubbia highlights the similarity between the science and arts. Just like the process of creating art, scientific discovery is to some extent irrational and guided by intuition. The arts and humanities deepen our understanding of human experiences and perspectives, complementing the empirical data provided by the sciences. In other words, they help us understand how measurable factors such as monetary costs, waiting time, and length of stay relate to the human experience. Recognizing the value of humanities in healthcare, my organization has established its very own Medical Humanities Institute to drive development in this field. As a joint academic institute, it integrates the academic strengths of Duke NUS Medical School with the clinical expertise of the Sing Health institutions. Ultimately, it aims to address the depersonalization of modern healthcare, foster a more humanistic practice of medicine, and support ethical analysis. So to wrap things up, in the modern healthcare landscape, technological and scientific advancements had led to improved health outcomes and longer lifespans. However, these gains come at a cost where healthcare provision is becoming less personal as professionals increasingly rely on technology, shifting their focus away from patients and de-emphasizing the human touch. So this phenomenon might be especially apparent in fields like diagnostic radiography and radiation therapy, where technology lies at the core of our practice. Unfortunately, the biomedical model, which reduces patients to test results and diagnosis, is unable to fully address the complex needs of individuals. While the science of medicine provides answers to the facts of nature, it struggles to account for the lived experiences, values, and aspirations of patients. This is where the arts and humanities become relevant. They complement the sciences to complete the practice of medicine, helping to bridge the gap between treating the disease and caring for the person. So I would like to conclude my presentation with a quote you see on this slide. People don't care how much you know until they know how much you care. While patients expect technical excellence as a baseline, they also look for compassion, emotional intelligence, and professionalism in their healthcare providers. As such, while my topic may be somewhat unconventional for a radiography conference, which tends to lean towards the technical aspects of our work, I believe that it can add real value to our profession and transform practice. Even if you are not in a position to immediately introduce medical humanities to your organizations, having some awareness of its relevance is a meaningful first step. This way, it might inspire you to seek out opportunities for engagement with the field, or even spark change within your own sphere of influence. So I'd like to take this opportunity to acknowledge and thank the people who supported me in this journey. In particular, I would like to express my appreciation for my honors thesis supervisor, Prof. Sharon Wong, for her guidance and encouragement as I navigated the world of research. And here are my references. Thank you.
Thank you, Lola, for the great presentation. Okay, up next, we have Lily Lai, who is a principal radiographer at Khoo Park Hospital with over 30 years of clinical experience. So Lily specializes in breast imaging and received the prestigious HMDT trainings in the UK in 2002, as well as the MD Anderson Cancer Center in the US. So Lily currently holds a master's in health science management and will be sharing an intelligent imaging. So without further ado, Lily, please.
Give me a minute. I need to share my screen. Good afternoon, everybody. Can you hear me?
Oh yeah, we can hear you. Maybe you can
Okay,
go
great.
a bit louder. Thank you.
All right, I'll speak a bit louder. Well, I got, I think 15 minutes to wrap up by 4 p.m. I hope I can actually complete the presentation on time. Okay, today, what I'm going to share, right, is going to be just in front of you, the slides, okay? Can see that we want to talk about mammography. And of course, you know, the insight and the transformation that I'm going to share based on the 3 areas of technology that have evolved over the years. And of course, the future direction. And if I have the time, I'll share some case studies. And of course, conclusion at the end. Right. You can see on this picture, right? You can see CT scan, MRI. Mammography for many, right, is often seen as a modest modality, you know, something that is small, sometimes even underestimated. It's not typically the first choice, but comes to mind when radiographer consider a subspecialty. You know, most people will choose CT scan, MRI, which actually give you the excitement, you know, even interventional radiology. So to you know, to a lot of people, mammography, you know, appear at first glance as a routine or even a limited in scope. Well, so today, I'm going to share a little bit more on what you can learn in mammography. It's not just doing a mammogram, but there'll be more than that. However, you know, a lot of people miss the mark to, you know, not understanding this. But for me, that have been doing mammography for the past 30 years, I believe that mammography over years have definitely evolved significantly. What began as a basic two projection mammogram, you know, it has transformed now into something that actually play a very critical role, especially in the early detection of diagnosis of breast cancer. So for those that have already specialized in mammography, probably will kind of agree what I say. Right. So not everyone's first choice, but mammography is always something that look like it's easy to learn. However, you know, there is a lot more to it, whereby you need deep technical skills in positioning, and you need to have strong patient interpersonal skills. Like earlier radiographers have shared regarding, you know, how to make the patients comfortable when they are in the room, the empathy portion of it, you know, all these actually make the patient's experience to be more holistic, you know, and especially in terms of mammography, whereby you need to go into the room and you need to undress, you know. So thank you for the radiographer that shared regarding the intuitive or the cognitive aspect of, you know, being a radiographer, how to make your patients more comfortable. So today, I'm going to share regarding three areas in mammography that is beyond just the true projection. First, I'm going to share about 3D mammography, which is now is a very common technology in most of the mammography units in Singapore, we do have this application. Other than the screening center, sometimes may not have this function, but most of the big hospitals, they have this function of 3D mammography. And the second one is about contrast enhanced mammography. And the last is regarding AI, which is something is a hot topic in all walks of life, not just mammography or not only medical imaging, but also in your daily life, whereby you probably need a lot of help. The most popular is ChatGPT, right? All right, so I'm going into the details of the 3D mammography. Well, just to share a little bit more, I hope that I won't overrun. You can see on the left side diagram, right? It's a 2D imaging, which is most people know that when you actually do the mammogram, overlapping of anatomy structure is actually quite common, especially in mammography that actually can mask suspicious lesions. In certain conditions, you know, there's some noise lesions that look like as if it's actually real, but actually it's not. So the 3D mammography will come into the picture. So on the right, you can see the diagram about tomosynthesis is the other word we use for 3D mammography. The breast is compressed like the traditional mammogram, but instead of taking just one image, the X-ray arm swing in an arc over the breast, capturing thousands of thin slices. Typically, the angulation is between 15 to 50 degrees arc. Yeah, think of it like, you know, you're flipping through the page of a book. Each slice gives a clearer pictures of the structure inside the breast, making it easier to spot abnormalities that might be hidden in a standard 2D mammogram. Yes, so you can see the picture here is the same area of the breast. You can see on the left side, the 2D image is actually with overlapping of tissues that you can't see the true speculated mass. And on the right side, with DPT, which meaning tomosynthesis itself, you can see the two stellate lesion over here. One is here, one is here. Yes. Moving on. Okay. I would like to share this study, which is actually done by VIA-PE, that regarding how the impact of 3D mammogram, not just in terms of doing tomosynthesis, but as technology advances, the tomosynthesis itself has also come out with, we call that the synthesized 2D mammogram together. It means that when you actually do a 3D mammogram, it actually post-process a 2D mammogram for you. For this, it will actually save some dose to the patient. If you do mammogram plus a 3D mammogram, you will have like double the dose or even more. But with a synthesized mammogram plus a 3D mammogram, the dose will be less, slightly a bit more than a standard 2D, but it will actually help with radiation reduction to the patient. But of course, you know, this is important. This study shows that, you know, they actually evaluated the image quality, the lesions detection rate, and the recall rates and the radiation dose. It seems like the desirable selection should be a synthesized mammogram with a 3D mammography. You can read a little bit more in this paper that is on the slides. You can put it, take it down if you want. So basically, to cut short, 3D mammogram itself helps to reduce the recall rates. Why? Because with the thin slices, you're able to pick up more things straight away based on the 3D mammogram. You do not need to call the patient back to do additional views. Reductions of repeat scans as the same thing as the first point. And of course, offer an improved detection. You can pick up things that's been obscured by the 2D mammogram. And of course, last but not least is the radiation dose. Right. So now I move on to contrast enhanced mammography. This technology itself, right, is something that has been around already for the past 5 to 10 years, I think. Basically, I will just give you an overview of how the procedure is and what does it do. Basically, enhanced contrast enhanced mammography give a IV injection of iodine-based dye, and these dye highlight the abnormal blood vessels around the suspicious lesion, and it actually can show that if maybe there is a cancer that's developing over the area. Yeah, and the functionality of the breast tissue, and also enable early detection of breast cancer. And currently, this technology is already FDA approved, and many centers have been using. Even my centers, we are actually, performing this procedure. Yes. So actually, what is the indication of contrast enhanced? Usually, you can see that patients that actually are high-risk patient in terms of breast cancer, they have a strong family history of breast cancer, or they actually have some diagnosis of atypical cells, and they cannot do the MRI for whatever reasons. They can use contrast enhanced mammography to evaluate any suspicious finding from the standard mammogram. Yes, to determine how much cancer can spread within the breast, and the breast region that are mammographic and sonographically opt out due to dense breast. You can actually use this procedure to help you with diagnosis. Yes. But of course, there are some contraindication of contrast enhanced. Like for example, if you are pregnant, you cannot do that radiation. And of course, if you are allergic to the iodine. And another one is kidney impairment. Like if you have kidney disease, you probably can't take the contrast injection. And of course, some of the patients that cannot tolerate the compression of doing a mammogram also will not be able to do this procedure. Yes. So just a rough, quick how this procedure is being conducted. Yeah, this procedure is conducted. I left, I think, 5 minutes ago. Okay, I'll do a quick one. Basically, you inject the contrast. You are just doing a normal mammogram. After 2 minutes, when the contrast is being injected into the veins. And what happens is that you make 2 exposure, and one exposure is the low energy, and the other exposure is a high energy. So the combined logarithm of these 2 images, right, will produce you the contrast enhanced imaging. And the whole process took around 30 minutes, though the imaging itself only take like around 8 minutes. Yes. Yes. So now I talk about the advantage and the goodness of the benefit of contrast. It's cost effective, it's less affected by breast density. Contraindication for MRI, as I have mentioned earlier, claustrophobic patients that is not able to perform MRI, they can do contrast enhanced mammography as the second option. Right, this is a picture of how the CEM is being shown right in front of you. Left side is a standard 2D mammogram. And when you actually, after the injection and the subtraction, this is how it looks like. All the breast tissue will be subtracted away and left with the lesions that is actually contrast enhanced. Okay, last but not least, I'm going to share a little bit on artificial intelligence in mammography. I think AI is something that is now is somehow integrated into our lifestyle. It's quite common and it's a hot topic. So the question is, how does AI, apply in mammography? Basically, AI system, as we all know, is about building using deep learning and learn to detect patterns associated with breast cancer. Sorry. Yes, and you can assign a malignancy likelihood score to the area of interest. Later, I'll share a little bit more on the scoring. All right. So why we need AI in mammography? Basically, right, there's a shortage of breast radiologists, and the doctors are really reading a lot of mammograms, especially for the screening group of patients. Patients that come in as a screening to check whether they have any breast cancer or not. The doctors is tired with the eye with the read like thousands of mammograms every day. So the AI is there to help, is designed to assist them, to help them to detect subtle signs of cancer that they may miss. Yes, and to enhance accuracy, of course, definitely is to reduce workload because basically the AI itself is like another radiologist that can help you to read some of the screening mammogram. Yeah, so in the clinical setting, by this paper, it shares that, AI actually assists in many, many ways. As I mentioned, we flag out suspicious lesion so that the radiologist can give a second look on the mammogram itself again. And of course, providing a scoring to help you to prioritize your cases. Maybe this case you need to actually fast track them for a biopsy and comparing with current images with prior mammogram and identify cases likely to be normal. Yes, so that we can give priority to the urgent cases. Right. So the advantage, as I have mentioned again, improve cancer detection, reduce recall rate, and time saving and efficiency gain. I think I will move on a little bit faster. On this slide, I will want to share the human elements of AI in terms of assisting the radiologist in reading mammography. So in the study, it actually mentions regarding AI, how does AI assist the radiologist? Basically, the study shows that the AI model outperform individual radiologists in detecting breast cancer and also reduce false positive and false negative. But however, we need to know that is AI plus radiologist performance was superior to either alone. So it means that if you just let the AI run or let the radiologist run, it's not as good as both of them actually combined together. Yes, the future likely lies on the collaborative intelligence of radiologists and AI working together, which is something that I believe that is already happening in all the hospitals. Just to take note that the AI is never to replace the human being, which is the radiologist, whereas it actually helps to give them the opportunity to improve their skills, to improve their accuracy, and of course, lastly, to enhance patient care because you have more time for the patient, where the AI actually helps you to do some of your work. And this is a statement that I found on the internet, that behind every image is a life, and behind every scan there's a story. So this is where I start my case studies. I'm going to share just a few studies. I think I will just need another 5 minutes. I believe I should be able to complete the presentation. So the first case is actually a 62-year-old woman that with invasive ductal carcinoma of the superior medial right breast. Yes. So I just want to show that how 3D mammography helps in identifying, detecting lesions that is actually blocked by the breast tissue due to overlapping tissues in the breast. You can see on the left is a normal 2D mammogram, but on the right side, you can see the arrow pointing at the distortion or the stellate lesion that is clearly demonstrated in the 3D mammogram. And this is a cancer. The second case is about contrast enhanced. We have these 69-year-old patients, come with the history of right mastectomy. She actually is a cancer patient. And the mammogram shows effector distortion on the central left breast. But the contrast enhanced actually didn't enhance on that area of distortion. So highly possible that the distortion is caused by the scarring due to post-surgery from a prior breast surgery. Right. So then, what does the contrast enhanced pick up? It pick up an enhanced nodule at the upper outer periareolar area that is obscured by the dense fibroglandular tissue over here. All right, you can see the arrow pointing at that little small thing. So under ultrasound, they did a biopsy and actually demonstrated that it's a low grade in intraductal carcinoma. Yes. And the third case, this is about AI that I'm sharing. This patient have a long history. She's 53 years old. She actually did a biopsy on her right and her left breast, and her right side was diagnosed with ADH, which is called the atypical ductal hyperplasia in 2022. And of course, the left side is neoplasia. This one is probably fibrocystic pain. But however, patient has very strong family history of breast cancer. The auntie and the mothers all is diagnosed with breast cancer. That's why she is required for a yearly screening. So she has been diligently doing her mammogram every year, 2022, 23, 24. And in 2025, she came for her mammogram screening again. And this is what the AI picked up. You can see that on the left breast, right, there's some density. But amazingly, the AI seems to have learned and did not highlight that area, knowing that she has these lesions for probably the past a couple of years based on comparison of the images. But whereas on the right side, there is an area of highlighted area. These two areas that is green, that it was highlighted by the AI. And what does it represent? You can see there are some numbers over there. M is stands for masses, and C is calcification. And there's a scoring of 1 to 100. So the higher the score, the higher that the suspicious level of that area of concern. And of course, on the bottom part, you can see this area of Biret's density is just to tell you what type of breast is this, in terms of fatty content or dense breast content. Yeah, so it's actually a scale of 1 to 10. This is how you actually look at the AI report. Yes. So for this patient, they found the calcification on the right. It helps the radiologist to zoom in to look at that area of concern after they saw that the AI it was highlighted. In the past years, it has been called as stable, no change. Yes, but because the AI highlighted it, they actually went in to ask for a magnification view, and we saw some suspicious microcalcification where the arrow is pointing, and this is the other view, all right, which is the MLO view. Same thing, you can see the arrow. Yeah, these are the calcification that is suspicious, and actually it warrant excision biopsy. But however, we do not have the histological report result of this surgery because patient is still thinking whether she wants to go for the operation. Yeah, I think I'm going to skip the other two case study, and I'm going to end my conclusion since I see Nathaniel appearing. Okay, so come back to the same slides that I had earlier, that, the future lies on collaborative intelligence, because it's important that the AI is there to assist the radiologist. I do have a case actually want to share, but I think due to time constraint, I probably didn't share that, but have a quick word is that, there are cases that are cancer cases, but the AI is not able to pick up. Yes, so you still need the radiologist. It's not there to replace the radiologist, but to help them. Yeah, so before we end, just to share that what is the future direction for mammography itself, from 3D imaging to AI interpretation, from screening to biopsy, we can see that the future of mammography is not just two projection. There's much more to it. Yes, you follow the patient's pathway from the day that they were diagnosed with a suspicious lesion to the day that they went for a biopsy and the outcome of the biopsy, and also follow up, post-surgery mammogram, for the patient that actually need a lot of commitment and as well as a lot of passion. Yes, with this, I just conclude that, definitely with all the advancement in technology, in 3D, in contrast enhanced, it actually helps to make mammography or the diagnosis of breast cancer to be more sensitive and more accurate. Yes, so that we are able to allow for timely intervention, means that early detections will definitely help to improve patients' outcome, because patients probably will just need a surgery without any radiotherapy or even chemotherapy if it's being detected even before the stage 0. Yes, with this, I end my presentation. Thank you very much. Here is all my references. Thank you.
Okay, thank you so much, Lily.
I think I should stop sharing. Oh, sorry.
Okay, so
Right.
we would like to thank all the 4 wonderful speakers who presented well today. Sam, Esty, Lele, and Lily as well. So speaking for myself, I had many takeaways from today's presentation, and I'm sure everyone felt the same as well. So thank you guys again for the insightful and thoughtful presentation and for your time today. So on the Q&A chat box, there were 2 questions raised by Harris on how hospital team leaders can adopt PCC. So this was actually already answered by Sam. So I don't see any other questions on the chat, but not to worry. Should you have any inquiries, please direct them to this email as well. So we will direct them to the speakers and